So I just want to touch very briefly on acute management. I'm going to confess this whole morning is very weak on acute management because I'm very much interested in chronic management of asthma and prevention. But I just thought I'd cover this because there is kind of a progression from bronchiolitis to preschool wheeze to asthma. And the management doesn't suddenly change, it kind of gradually progresses, and it's important to remember just because you're 5, you don't magically start responding to drugs. It kind of happens over some period. So acute management of bronchiolitis. So in New Zealand, we would tend to use a definition of children less than 1 year. You've got to be careful reading American literature because they'll talk about children less than 2 years. And I think children from 1 to 2 are different. When we talk about asthma, we're talking about bronchospasm as being kind of the thing we're really worried about and trying to treat. That is not the case in bronchiolitis. It's airway edema and mucus and inflammation clogging the airways. So those are making the airways narrow and the child wheezy, but you don't have smooth muscle constriction that you want to relax with salbutamol. So bronchodilators don't work. Multiple trials, every 5 years somebody thinks surely bronchodilators will work, and we get another trial which doesn't quite reach significance. So current management is largely supportive, which is oxygen, feeds if they're dehydrated, and hand washing to prevent spread. Then we move on to the children who are 1 to 4 years old. Sorry, I'll just go back to that. So in this age group, it's very much about gritting your teeth, waiting for the illness to get better, and getting the child to hospital if they need to be there. That's about it. Children 1 to 4 years. So there's a gradually increasing number of kids will respond to salbutamol over kind of 1 to 4 years of age, until by school age they almost all do. So in this group we do give salbutamol because it is effective, as opposed to kids under 1 where it's not effective. The kids 1 to 2 are kind of in between, so some of them will respond, some won't. Oral steroids at this stage, and I think that's important, at this stage, there is no evidence for the effectiveness of oral steroids in children less than 5 years. Plus, we all know that steroids are harmful in multiple ways. So I think at this stage, and this could change next year, we would not recommend giving steroids to children with preschool wheeze. We have done randomised trials in Auckland and trying to show this, and the problem is that most kids with 1 to 4 years with wheeze are better anyway. So we kind of felt the steroids were helping, but actually the kids got better at the same time. So there was no advantage to giving the steroids. We're currently trying to do a trial where to prove that, so a much bigger trial to prove that there's no difference, as opposed to trying to show a difference. We're trying to prove that there is no difference. So we'll come out with a definitive answer that children in this age group should not receive steroids. Because we're chickens, we still give steroids to children who are in hospital and on oxygen, but that doesn't apply to any of you. And this is a similar trial. This is a child, kids 10 to 50 months, who presented. These children were admitted to hospital with preschool wheeze, and half were given prednisone and half weren't. And you can see it took just as long to get out of hospital whether you got prednisone or not. This is a pretty big style study for kids. And we've found almost exactly the same thing in our study of about 400 kids. So really no benefit. Oh, sorry, that's where I was meant to stop. Stopped a bit early. Any questions about that bit?
Yeah, just a comment that if we sent every kid who we think is sick enough to have oral steroids, if we sent every kid like that to hospital for oxygen, man, you would have a big crisis overnight.
Oh, yeah, but no, they need to go to hospital if they need oxygen. Right. The steroids don't do anything. You don't have to send them to hospital to get steroids because the steroids don't do anything. You have to send them to hospital if they need fluids or oxygen.
Can I ask where you were, Andrew?
What's that?
When you were
YD.
Yeah. I guess it's quite hard to sit on a child at home, particularly if there's history with like steroids and Hard to sit on it.
But you're not going to give them simvastatin, and you're not going to give them captopril either. You know, it's just the same. It's not a drug. It's just not indicated. And it is very difficult to change. It's very difficult to change your own practice. It's very difficult to change family practice if they're used to something. And it's very difficult to change a whole country's cultural practice about how to manage preschool wheeze. So I'm not really fussed about it because I know that there's lots of people out there still doing that. And I know it'll be probably decades before, you know, we actually stop doing this.
And I make a comment from the healthy long study didn't show any the primary outcome of bronchioliotis, but what it did, and we haven't written this up and it's still anecdotal, but it was health literacy of parents that really improved. And I think that's where in primary care we've got a real responsibility, is teaching parents what life-threatening preschool wheeze, asthma looks like, not giving them drugs.
You're talking before about the difference between cultural sort of versions of wheeze. In some cultures using the same terminology as a cough and a wheeze. Which cultures are those?
Asian, some dialects in China. But we've had some really interesting experiences with Pacific Island families. So one of my colleagues goes to Samoa, and you know, she says, "Do any of the patients cough?" And they say no. And she's standing in the ward, and there's 20 children all round her coughing right in front of her. And we get the same thing in our clinics. Does your child cough? No. But you know, the child's coughing right there in front of you. So partly it's awareness, partly it's switching off. I think it's also, rather than culture, it was language. You know, they just don't have a word for the wheeze that's different. 50 words for snow, but no word for wheeze. Got 4 cases here. I've been told by my colleagues that's going to take an hour, but I think it's only going to take 5 minutes. So we'll see how we go. So case 1. So this is, I got phoned by a doctor from another hospital, 10-month-old, wheeze since 3 to 4 months of age, worse when feeding or playing, not responding to salbutamol or Atrovent, which we wouldn't expect, and growing well. And I think just the lesson from this case was, what was the next question I asked? Have you been listening?
What is the wheeze? What do you mean by
Yeah. Excellent. So this baby had tachypnea with wheeze all the time. So this is clearly not asthma or bronchiolitis. This is a congenital narrowing of the airway. So he came up to Auckland, had a bronchoscopy, and he had quite severe tracheomalacia. So a lesson from this case is beware of daily wheeze in a young baby. Case 2, 4-year-old girl.
Can I just ask, is it what used to be called the heavy wheezer? The chubby name that was...
No, so that would be more a child with bronchiolitis who's quite wheezy with the bronchiolitis, but not distressed about it. No, the happy wheezer was very much an acute thing that went away. So they'd be well in between.
I thought tracheomalacia would have more of a striker.
Depends how low it is. This was right down the bottom. But it's also very hard. I mean, write textbooks make it sound easy to separate stridor and wheeze. It's actually quite difficult. They sound, in young kids, they sound the same. And you know, stridor is supposed to be on inspiration and wheeze is supposed to be on expiration, but in young kids they seem to have it in both for both of them, and it's actually slightly tricky. Next case, 4-year-old girl, 2 previous admits with wheeze requiring IV treatment, so very sick. And one of them was one of the things I look out for is, this kid's coming in acutely with wheeze. Did they actually have a virus that we've identified that would cause that illness? Because I get really worried if they don't. Presented again with wheeze requiring ICU, and this time with the rhinovirus. They're on Flixtide. Normally, they don't have any interval symptoms except some salbutamol with exercise, no eczema or hay fever, but has a history with asthma. So we're already on Flixtide. What preventive treatment next? Montelukast, cool. So so this is a historic case. This is with the old funding. So added Montelukast to be given at the first sign of a cold. But now this child's actually on continuous Montelukast because it's funded now. Discharged from clinic because they look fine, but actually came back to ICU the very next day. So even monkeys fall out of trees. Now on regular Flixitide and regular Montelukast, and I had to bump this up to the adult dose. So for children under 5, the dose is 4 milligrams. For children over 5, it's 5 milligrams, but they're actually different tablets with different formulations. So that 5 milligrams is actually a much higher dose of the effective drug because it's just got a different salt on the end of it. And the adult dose is 10 milligrams. So I've bumped this kid up to 10 milligrams because usually kids don't actually get many side effects with Montelukast if they tolerate it, so you can push the dose quite high. And now currently has no interval symptoms or regular salbutamol, and fingers crossed they don't embarrass me again next time I try and discharge them from my clinic. So lessons from this case, I think with the funding changing, regular Montelukast is better than as needed. And just that thing that we can give inhaled corticosteroids for those interval symptoms, but we can't necessarily prevent the exacerbations. So the virus comes along and gives the kids such a big inflammatory surge that no matter what we're doing, they're still going to come into hospital. But we can reduce the interval symptoms and we can improve the quality of life. And I'm hoping that at the very least I can keep the child out of ICU. If I can't keep them out of hospital, at least I can keep them out of ICU with all this treatment. Case 3.
Can I just ask a question? How long do you put them on Montelukast for then in that case?
So having said that you should only give inhaled corticosteroids for 3 months, I actually just give them the Montelukast till they reach school age and the funding criteria change.
Okay. So long-term
Yeah, and it's because it's about the exacerbations and they're going to have 6 to 8 viruses per year. So the treatment's kind of there for that kind of monthly or 2-monthly episode.
And what age, sorry Dave, what age would you start them then?
I think the youngest I've done is 18 months,
Okay.
but because of that swallowing a tablet thing, it should be 2 years. And you just got to be really aware about not having the child choke on a tablet when they're really young.
It's very ignorant.
Yeah. So the original randomised trials were quite long. I think but we don't have trials that are 5 years or 10 years long in the same way that we have with the inhaled steroids. But inhaled steroids are right up at the top of that cascade. They have lots of effects. You'd expect lots of side effects, whereas Montelukast right down the bottom, just acting on one receptor, you kind of wouldn't expect much. It seems pretty benign. Okay, next case, it's a difficult age, not even 2. 14-month-old presented to ICU with wheeze, severe wheeze and coryza, ex-34-week infant. What question next? That's really vague. Next question is really interval symptoms. What are they like normally? They're using salbutamol about 2 times per week. So that quite regular interval symptoms. So I started them on Flixitide and had resolution of the interval symptoms, but unfortunately, as expected, ongoing exacerbations. And my plan with this one is to start Montelukast if she ends up in ICU again. So, lesson from this one is if they've got that interval symptoms with a multi-trigger wheeze, they will benefit from inhaled corticosteroids. And so that's the key question in differentiating those phenotypes. Do they have symptoms between exacerbations? Last case, I think. 15-month-old. 2 presentations at ICU with coryza and wheeze in the past 2 months, plus 1 previous admission. What are you going to ask next? Again, pretty vague. Wheeze every day. Also, the interval symptoms. Also, any signs of chronic disease. No regular symptoms of wheeze or exercise, as much as 15-month-olds exercise. Commenced on Montelukast, and I've got this situation where I've got children in ICU, so I kind of throw everything at them. And again, no further problems 6 months later. So these treatments do work.
So you gave it even though it was only 15 months old, you gave it Montelukast?
Yeah, so this is one of the ones I got the parents crush the tablet.
So what age would be your youngest you would give that and say you put it?
That would be the youngest. That's the youngest one I've done it. And that was a bit iffy, I think. So montelukast is effective for episodic wheeze with no interval symptoms. But again, this could have been October, and then we've gone into summer, so the child might have just caught no viruses anyway. It's one of the difficulties of dealing with chronic disease is you kind of don't really know if you've made a difference. Cool. Any discussions about those cases? Tom?
Not about the cases, but I've often come across a paradox with children that appear to be wheezing, but you can't hear anything in their chest. Is that just likely to be sort of weak lungs, more sort of typical of bronchiolitis, or?
Okay, so children can be hard to examine because when you listen to an adult's chest, you get them to take big breaths in and out. So they actually move a lot more air than normal, so you can bring out the wheeze. And kids, you can't do that. So for kids who are a bit cooperative, I always get them to cough, so you can hear for the wheezy sort of cough. But then for those other kids who are just sitting there, then I really focus on that inspiratory to expiratory ratio. So if you've got narrowed airways, it takes longer to move air through that obstruction. So on inspiration with stridor, you have a long in-breath and a short out-breath. But with wheeze, in the lower airways, you have a short in-breath, but then it takes a long time to breathe out. So that would be the next sign that I would go to. They probably are a bit wheezy. They're just not cooperating with you to give those big breaths.
Are we likely to cause harm to kids by prescribing them LABA in order that they will meet the special authority criteria for montelukast in the future, or are LABAs reasonably inert to prescribe for that purpose?
So I think LABAs really is about school-age asthma, so I'll cover that after morning tea.
So when you say it's difficult for examine, would you suggest in primary care that we do SACs regularly?
No.
Because there was one study,
Yeah.
voluntary around the value of SACs in determining pneumonia prognosis.
Yeah, so I guess there's a big difference between a child who's acutely sick and chronically sick, but well when you see them on the day. I think for most patients who you're talking about chronic symptoms, on the day you see them in clinic, there's not much point doing SATs. But when you see them acutely, I think I would measure SATs if you can. I think with little kids, you have to have the right size probe. Otherwise, you're going to get falsely low SATs, and then you're going to get really embarrassed because you sent this kid to hospital with SATs of 82 when actually they're 100. So there's no point trying to get a big fat adult probe onto a small little finger. You have to have the right equipment.
I just think that's another thing that I wonder in primary care, how many people actually do measure SATs, because all our kids can acutely.
Yeah, I think most people would measure SATs with acutely sick kids. Yeah. I think the equipment's pretty widely distributed. It's just making sure you've got the right stuff.
What sort of approaches do you use to try and reduce those stats of Māori and Pacific presentation to hospital?
So I think we can do that with asthma, with the school-age kids, with preventative treatment, and hopefully we can address that this afternoon. Number one thing is stopping smoking. Number two thing is overcrowding in housing. And number three is healthy homes with insulation and dry housing. I think each DHB's got its own little program for healthy housing. So all our chronically sick kids, we're referring to that program. It's called ARFI in Auckland, but your own DHB will have a different program. I think it's probably or possibly something cultural about the way people live that we don't appreciate.
The way we communicate, because as you alluded before, you don't know what you don't know. You don't know what you don't know, and you know what you know. Often parents will not really understand what's happening, perhaps. So perhaps it's about us too communicating and being able to communicate and engage.
Yeah.
It's also priority in people's families. What may be a priority for me, for example, may not be a priority for a family that has, a lot of children, has 3 jobs. I'm up against work 3 jobs, trying to survive. So, there's all those out there.
Yeah, but also dealing with other family members who might smoke. You might be able to say you can't come to my house, but other people can't. Or other family members who need somewhere to live. You might be able to say sort yourself out, but other people can't.
And also collective cultures operate differently in terms of who's providing care for children, who's giving them food, who's giving them medicine. And if you're talking to one person in a family, that may not be the person that actually has the, who has the, who does the things in that family.
But as well with the Sue Pringle study, do you also have a real clear plan for the GP once they're discharged, or a discharge plan, so the GP is maybe picking it up and becoming more proactive in the primary care centre? Because that's what's part of it, is that my Pacific.
We probably don't discharge our patients until they've seen a social worker, gone through that process. In fact, we tend not to, I'm getting chronic patients who come into our service and stay till they become adults, really. But we try and sort out the housing and things before we discharge them, because we can't discharge them till they're well.
But just following up your point, in terms of, as I keep going on about healthy study, it was quite profound how people would say, I understand now what you mean. So we've spent so much time, and there've been more than one professional talking to them, and there's been a community health worker talking to them about how they treated or how they used the medication. I think we have got a part to play as professionals in making sure people actually understand what we know.
Yes, that's right. So that's why I'm asking the question that we all need to sort of pick up and,
we all need to
support
look at ourselves
and be proactive and things like that.
Because some people just say yes, and they want you to, they want to appeal to you and think that you not take your time.
But if we know that there's not enough treatment being provided, then we as all professionals need to make sure that we're being just that little bit more proactive and analysing what's happening.
I think that's kind of going to be what we're talking about next, and it's all really important. But I think in terms of preventing morbidity and mortality amongst Maori and Pacific Islanders, I think the social situation and the housing, which unfortunately I'm not going to talk about much, is really important, and the social determinants of health are really important.
I think a lot of control. Okay, I totally agree with you in the utopia world also, but if that's not what we've identified, find evidence that as practitioners we have the ability to be able to make that change, then let's be proactive about it. So when somebody's presenting, let's use all those negative stats that we chuck around the room, and let's put action to it.
I was just going to add that I think there's too many mixed messages as well, and that's quite confusing for families, and that a lot of us can teach differently as well in the message that we're giving. So I think with nurses and doctors we need to just be better at teaching and using the more simple.
Okay, that's the perfect note to stop on.